Hello, my name is Anna Vega. I'm an infectious diseases pharmacist at Jackson Memorial Hospital. And in this updated presentation, I will be covering new trials for the use of tocilizumab in COVID-19 pneumonia. This slide gives an overview of some of the early published case reports for tocilizumab for COVID-19 pneumonia. These case reports had mixed results, and compared to the data that we have now, they represent lower quality evidence as they're just an N of 1 with no comparator group. The first two case reports included patients with a history of malignancy who were admitted for mild to moderate COVID-19 pneumonia, received tocilizumab one-time dose, and saw a quick improvement of their symptoms as well as CT chest imaging. The last two case reports, however, included patients who had severe COVID-19 pneumonia requiring mechanical ventilation, and despite getting tocilizumab, progressed to ARDS septic shock and did not survive. For more details on these case reports, please refer to the previous version of these slides. Similarly, this slide gives a quick overview of some of the early published case series of tocilizumab for COVID-19 pneumonia. The first one and most widely cited one is by Zhu and colleagues, which included 21 patients in China with severe or critical COVID-19 who, after receiving tocilizumab within 24 hours, had defervesced, and 75% had clinical improvement in terms of their oxygen requirement. Overall, this was a positive study for tocilizumab. The other two case series are listed here for your reference, and for more details, please refer to the earlier version of these slides. In this slide, I have summarized the past 5 retrospective observational studies that I've discussed, and I just want to highlight some major points about each so that we can keep track of all the information that we've looked at. The first study by Martinez-Sanz and colleagues out of Madrid looked at patients with moderate disease who were not in the ICU. The primary outcome was time to death, and there was no safety analysis. This was overall a positive study for tocilizumab that showed that the drug is linked to decreased time to mortality in patients with systemic inflammation, specifically an elevated CRP level. The second study by Biran and colleagues looked at severe patients in the ICU only. The primary outcome was time to hospital mortality. In terms of safety, there was no significant difference between groups in terms of bacterial infections or other secondary infections. And again, this was a positive study for tocilizumab, which showed that the drug is associated in this cohort with a reduced in-hospital mortality rate in those younger than 65 and those with an elevated CRP level. The third study, the Tiseo study by Guaraldi and colleagues, also looked at patients with severe pneumonia based on the Chinese clinical guidelines. However, only 17% of these patients were mechanically ventilated in the ICU. The primary outcome was a composite of death or invasive mechanical ventilation. In terms of safety, they found significantly increased risk of secondary infections in the tocilizumab group. And overall, this was a positive study that showed a significant reduction in risk of mechanical ventilation or death. The fourth study by Summers and colleagues out of Michigan Medicine looked at severe COVID-19 in only mechanically ventilated patients. The primary outcome was survival probability after intubation. In terms of safety, they looked at infection risk and found again a significant increase in the risk of infections in the tocilizumab group. And this was also a positive study showing survival probability was significantly higher among tocilizumab treated patients. Lastly, the large Stop COVID retrospective study looked at severe ICU patients. The primary outcome was again time to mortality. They did not have a safety analysis, but overall this was a positive study for tocilizumab, showing that tocilizumab treated patients had lower adjusted risk of death. The first randomized controlled trial I will discuss is the RCT Tocilizumab COVID-19 study by Salvarini and colleagues, published in JAMA on October 20th. The objective of this study was to evaluate the effect of early tocilizumab administration versus standard therapy in preventing clinical worsening for patients hospitalized with COVID-19 pneumonia. This was a prospective open-label study that took place in 24 hospitals in Italy. The inclusion criteria was for adult patients older than 18 with PCR-confirmed SARS-CoV-2, a PF ratio between 200 and 300, and patients also had to have fever or elevated CRP levels. Exclusions were invasive or non-invasive mechanical ventilation at baseline, ICU admission, an allergy to tocilizumab, or any condition preventing future admission to the ICU. These included advanced age with multiple comorbidities, as well as the patient's expressed will to avoid future intubation. The primary outcome was a composite of entry into the ICU with mechanical ventilation, death, or clinical worsening defined by a PF ratio less than 150, whichever came first, and the secondary outcome was the rate of patients admitted to the ICU with invasive mechanical ventilation at 14 and 30 days. Some important baseline characteristics of the patients in this study are described here on this table. Overall, the median age of the cohort was 60 years, with no significant difference between the treatment and control arms. A majority of the patients in the study were male, and patients in the control arm were less likely to have inflammatory elevations at baseline and more likely to be treated with antivirals. This persisted despite randomization and may have led to bias towards the null. This slide shows the outcomes for the intention to treat population, which were very similar to the per protocol population. For the first part of the primary outcome, ICU admission within 14 days, this was met by 14 total patients with no significant difference between the groups and a relative risk of 1.26 with a 95% confidence interval that crosses 1. Similarly, for mortality at 14 days, there was no significant difference, and this was met by very few patients in the study. And in terms of clinical worsening, there was also no significant difference in this outcome, and this was met by 28.3% of patients in the tocilizumab group versus 27% in the standard of care group. In terms of adverse events, serious adverse events occurred in 3 patients, and none were considered to be treatment related by the site investigators. Other adverse events were increased ALT and decreased neutrophil count, which occurred more than twice as likely in the tocilizumab group. Some take-home points for this study are described below. One of the biggest strengths of the study was its randomized controlled trial design and the fact that it included 24 hospitals, which increases its external validity. This study, however, had several limitations. Firstly, it did not meet power as it had to be prematurely interrupted due to an interim analysis for futility. Second, it was an open-label study that was not placebo-controlled, which could bias the primary outcome assessment. The study had a low overall mortality rate, which could impact its external validity. Its exclusion criteria also could have introduced sampling bias, and its composite endpoint had components of varying clinical significance. Lastly, and most importantly, patients in the control arm were allowed to receive tocilizumab as rescue therapy, which makes it difficult to suss out the exact significance of tocilizumab on the outcomes of this study. The next study I will discuss is the randomized controlled Corumino 19 TOCI-1 study, which was an investigator-initiated, open-label, multi-center study in 9 French hospitals that used Bayesian modeling for its primary outcome. Patients were randomized to receive tocilizumab 8 milligrams per kilogram intravenously plus usual care or usual care alone, and usual care included antibiotics, antivirals, steroids, vasopressors, and anticoagulants. The outcome was to determine whether tocilizumab improved outcomes in patients hospitalized with moderate to severe COVID-19 pneumonia, and this was patients not requiring mechanical ventilation or ICU level of care at baseline. The primary outcome was a score higher than 5 on the World Health Organization Clinical Progression Scale by day 4, which I've included here on the right for reference. And as you can see, a score of 5 is given to a hospitalized patient who is requiring oxygen by mask or nasal prongs. The second primary outcome was survival without need of any ventilation on day 14. And the secondary outcomes are listed here for your reference. Patients included in this study had to be adults older than 18 years old with PCR-confirmed SARS-CoV-2 or typical CT findings, with moderate to severe pneumonia, meaning a WHO CPS score of 5, which is again those patients that are hospitalized and requiring oxygen through nasal cannula, but not requiring high flow, non-invasive ventilation like BiPAP or mechanical ventilation. The study excluded patients with an allergy to tocilizumab, those who were pregnant, those who had a documented bacterial infection, or patients with a low ANC, as described here on this slide, or platelets less than 50 grams per liter. The study flowchart is included here on the right for reference. Overall, 131 patients were randomized, 63 were analyzed for the tocilizumab group, and 67 for the standard of care group. There was no significant difference between groups at enrollment in terms of baseline characteristics. The median age of the overall cohort was 64 years, and a majority of patients were men. Most patients had PCR-confirmed infection, 89% in the tocilizumab group and 90% in the standard of care group. The oxygen need at baseline was a median of 5 liters per minute with a median saturation pressure of oxygen in blood of 95%. The most common comorbidities were diabetes and chronic cardiac disease, and patients in the standard of care group were more likely to receive antiviral drugs, glucocorticoids, and immunomodulators compared to patients in the tocilizumab group. For the first primary outcome, defined as a WHO CPS score greater than 5 by day 4, 12 patients, or 19% of the tocilizumab group, met this outcome compared to 19 patients, or 28%, of the usual care group, otherwise known as the standard of care group. This led to a median posterior absolute risk difference of -9 and a 90% credible interval of -21 to 3.1. This had a posterior probability of negative absolute risk difference of 89%, which did not achieve the 95% predefined efficacy threshold that I previously discussed in the last slide. Similar results in the PCR-confirmed disease sensitivity analyses were found. The results for the second primary outcome, which was the probability of survival without need for ventilation at day 14, are shown on this slide. As you can see on the table here on the right, by day 14, 12% fewer patients needed non-invasive or mechanical ventilation or died in the tocilizumab group than in the usual care group. This was 36% of patients in the usual care group and 24% of patients in the tocilizumab group. This led to a median posterior hazards ratio of 0.58 and a 90% credible interval of 0.33 to 1. The posterior probability of a hazards ratio less than 1 was 95.05%, which just barely crossed the predefined efficacy threshold of greater than 95%. However, this effect disappeared in the sensitivity analysis that looked at only PCR-confirmed disease, where the posterior probability of a hazard ratio less than 1 was 89.5%. Take-home points for this study. First, in terms of the positives, this was a randomized controlled multi-center study that uniquely used Bayesian modeling for the primary outcome. Overall, I would say this was a neutral to partially negative study for tocilizumab. It suggests that it may improve clinical progression at 14 days, but this effect disappeared when looking at only patients that had PCR-confirmed disease. In addition, the drug had no effect on mortality at day 14. In terms of the negative or limitations, this study had a small sample size, which could make it more difficult to find a difference between the groups, and it was open label. They had a very short follow-up period, only 4 days to see if a patient had clinically progressed and 14 days to assess mortality. Not all patients had PCR-confirmed disease, and this did show a difference when looking at the primary outcomes and looking at subgroup analyses only. More patients in the standard of care arm received glucocorticoids despite randomization, and this may have made a difference in terms of the rate of infections that we saw, which were higher in the standard of care arm. The odds ratios and hazards ratios were adjusted only for age and center for the primary and secondary outcomes. Missing data was considered primary outcome failure, which may have biased towards the null, and DNR orders were considered events in this study. Lastly, the most recently published randomized controlled trial on Tocilizumab is the BACC study published on October 21st in the New England Journal of Medicine. This study included patients 19 to 85 years old with PCR-confirmed disease who had at least one of the following inflammatory markers listed on this slide elevated. In addition, they had to show clinical signs of infection, including fever, pulmonary infiltrates, and a need for supplemental oxygen. They excluded patients who required more than 10 liters of supplemental oxygen and who were recently treated with a biologic agent or had diverticulitis. The intervention was Tocilizumab 8 milligrams per kilo compared to placebo, and the primary outcome was time to intubation or death. The flowchart for this study is included on the right for reference. Overall, 1,560 patients were screened, a majority were excluded, and in the end, 161 were randomized to receive Tocilizumab, 81 to receive placebo. There was no significant difference in terms of baseline characteristics between the groups. The median age of the cohort was 59.8 years, and patients older than 60 years were more likely to be in the Tocilizumab group, 37% versus 27% in the placebo group. A majority of patients were male, and 45% of patients were Hispanic or Latino. 80% were hospitalized in non-ICU hospital wards and were receiving supplemental oxygen with less than 6 liters per minute of oxygen nasal cannula. Hypertension was the most common comorbidity, and concomitant therapies did not differ between the groups and included remdesivir, hydroxychloroquine, and glucocorticoids. The results of the study are shown here. For the primary outcome of time to intubation or death, there was no significant difference between the groups, with a hazards ratio of 0.83 and a 95% confidence interval of 0.38 to 1.81. The primary outcome at 28 days was met by 17 patients in the Tocilizumab group versus 10 in the placebo group. This is also demonstrated on the right by the crossing lines on the Kaplan-Meier curve. In terms of the secondary outcomes of time to clinical worsening and time to discontinuation of supplemental oxygen, there was also no significant difference between the groups, and at 28 days, the numbers of patients that met each of these outcomes are listed here on the slide for reference. The take-home points for this study are, in terms of its strengths, it was a robust randomized controlled trial design with 7 Boston hospitals, and it was also double-blinded and placebo-controlled. For the limitations, this study had a relatively short follow-up period in regards to COVID-related mortality, which was 28 days. They also had a low primary event rate of 12%, which could have made it more difficult to find a difference between the groups without a larger sample size. The sample size calculation was only for 80% power in this study, and the imbalance of older patients in the Tocilizumab group may have affected the primary outcome, as subgroup analyses found that patients older than 65 were at higher risk for the primary outcome. The last 2 randomized controlled trials that I want to touch on are COVACTA and EMPACTA. These are double-blinded placebo-controlled trials that aren't fully published but do have some preliminary information available. These studies are a little bit more robust in design compared to Coromino and Salvarini studies that we previously reviewed, and they are much larger. In addition, in terms of clinical severity for enrollment, COVACTA is the outlier amongst all these studies in that it's focusing on critically ill patients, whereas these other randomized controlled trials on this table are focusing mostly on severe patients and not critically ill patients. In terms of the primary outcome, all the way at the right, we have EMPACTA. Their primary outcome was death or mechanical ventilation by day 28, and the threshold for efficacy was met in this study. In comparison, EMPACTA, their primary outcome was difference in clinical status using a 7-category scale by day 28, and the threshold for efficacy was not met in this study. Now, to make things even more clear, for Coromino, the study that we discussed in this slide deck that had 2 primary outcomes, they did not meet their first primary outcome, which was the WHO clinical progression scale score greater than 5 on day 4, but they did meet their secondary primary outcome, which was survival without need for mechanical ventilation by day 14. And then for the Salvarini study, they did not meet their primary outcome, which was PF ratio less than 150, ICU admission, or death. In terms of other relevant clinical trials, there is a lot of movement in this area, which is very exciting. I've listed here some of the trials on clinicaltrials.gov, and I've linked them for you here as well to the website for the 3 agents. Of note, for tocilizumab and sarilumab, there are randomized controlled trials underway with hopefully some more information available for COVID-19 in the next couple of weeks. For tocilizumab, we have some open label trials and observational case control studies, but we don't have any randomized controlled trials yet. In summary, optimal use of tocilizumab for patients with COVID-19 pneumonia with evidence of hyperinflammation has not yet been established. A growing number of retrospective observational studies demonstrate potential clinical efficacy and mortality benefit for tocilizumab, especially in severe and critically ill patients. However, only 2 of 5 currently available randomized controlled trials have met their primary efficacy outcomes. Fully published results from COVACTA, EMPACTA, and other RCTs are needed to inform clinical decisions. Currently, the National Institutes of Health and the Infectious Disease Society of America recommend against the use of tocilizumab unless in the context of a clinical trial.